And now we invite Dr. Rishma Pai. The audience does not need any introduction of Dr. Rishma Pai. And she'll be talking on intrauterine pathologies. Should they always be treated? So I think she will explain us which are the patients not to be operated rather than which are the patients to be operated.
Good morning to all of you. Pleasure to be here, back in the beautiful city of Bhubaneswar. Today I'm going to be talking to you on something which you deal with every single day, whatever kind of an OBGYN practitioner you are, and that is on intrauterine pathologies. But the question is, should they always be corrected? None of us want to overdo or overtreat our patients, and which is why we need to be very careful in this very sensitive area. Just like the seasons, medical concepts change with time, and all of us have to change with it. So just because when you were a medical student, every fibroid needed to be removed, it doesn't remain the case today when new studies and changes have come in. The one thing that remains constant, of course, is that the uterus is our first home. And so accurate evaluation and effective therapy are central to optimizing the conditions for implantation and sustained pregnancy. And we've all noticed that over the last few years, the number of couples with reproductive issues has increased dramatically. Even today, what is the best method of uterine cavity assessment is not decided. There's a lack of consensus. For years, hysteroscopy has been the gold standard. But it's a possibility that there may be similarly accurate, less invasive and less expensive tests. And one of them, as you all know, is transvaginal ultrasound, particularly for the diagnosis of polyps, especially when you add Doppler. It's an excellent test. For malformations and intrauterine adhesions, however, the sensitivity is low. And it provides, of course, excellent assessment of the myometrium at adnexal structures. And alongside, you can do an antral follicle count, which is very, very helpful. When you do a sonohysterography, so when you add saline to your sonography, it actually outperforms transvaginal sonography and HSG. It allows you to visualize the entire uterus in 3 different planes. You can pick up malformations, you can differentiate septum and bicornuate uterus. And so not many of us are using it today, but I think we should move towards this technique, which outperforms hysteroscopy. And you can see when a good sonologist is doing this, see the images. On the top, we have a normal, uterine cavity, and then we have adhesions, we have a septate uterus, and at the bottom, we have a submucous myoma. What more clarity than this do we need in a non-invasive technique? And so unnecessary, unproven, and uncomfortable diagnostic tests and procedures should be avoided, and we should move towards cost-effective techniques. So hysteroscopic management of specific adhesions should be individualized, and you may need more proof that every single thing that you see inside the uterus should be removed prior to ART. So let's be careful as we go forward. So the question is to do or not to do surgery in a particular patient. These intrauterine pathologies we can easily identify. We've been treating them for years, and maybe they have a benefit on reproductive outcomes. The polyps, the endometritis, synechiae, isthmoseals, leiomyomas, of course, Mullerian anomalies, retained products of conception, and of course, the tubal occlusions, which you can see hysteroscopically. Polyps, we know, have different mechanisms by which they impact fertility. Maybe a mechanical interference. The glands and the stroma and the polyps are actually unresponsive to progesterone stimulation, so they cause defective implantation. They produce local inflammation, and there's increased number of evidence of these mast cells in the cavity. And the polyps reduce messenger RNA levels of HOXA10 and 11, which we know are molecular markers for endometrial receptivity. So polyps affect the receptivity in many different ways. And hysteroscopic polypectomy has been the gold standard for years. You can do it in office procedure, or you can do a monopolar loop cautery, bipolar system, scissors. Most of the time nowadays I just use scissors when I'm doing a polypectomy, and we get really good outcomes. This is a case I did recently, huge polyps. These kind of polyps are definitely going to impact fertility. So, a recent study from the European segment, which said that the recommendations for polyp are transvaginal sonography should be imaging modality, polyps might alter receptivity, avoid DNC completely. It does not help in polyp removal. Office hysteroscopy is fantastic, and the removal of polyps as a routine practice is not currently supported by evidence. So all of us see a small little polyp, go ahead and remove it, not yet supported by evidence, and that's important for us to note. What about myomas? We all know that there's the Cochrane review a couple of years ago, huge benefit from the hysteroscopic removal of submucous myomas to improve pregnancy outcomes. All of us are very comfortable with resecting out the submucous myomas, either with monopolar or bipolar resectoscope, morcellator, some people, now even scissors, you cut around it, and then you can even use a myoma screw by the side of a hysteroscope and extract the smaller myomas. So different techniques of removing these submucous myomas, and there has been debate about whether even these fibroids affect fertility or not, and we'll come to that in a bit. So the recommendations for submucous myomas by the Canadian guidelines has been, of course, the standard methods of diagnosis, assess the size, location, the degree of invasion of the fibroid. Submucous myomas, all of us manage hysteroscopically, and they may have to be removed to improve fertility outcome. But none of the things we do post-operatively, give estrogen, put in a Foley's catheter, etc., none of them really seem to have big benefit. But this was a 2015 analysis, and after that, even submucous myoma options have changed, and I'll address that towards the end. What about adhesions? Intrauterine adhesions, we know, can disturb the cervico-uterotubal sperm transportation. They give you an avascular and an unresponsive endometrium, and obviously affect the receptivity. And not only that, once the patient becomes pregnant, there can be abnormal decidualization and abnormal placentation. So the impact of intrauterine adhesions on reproductive performance, even after adhesiolysis, is now becoming apparent. So there is a role for these adhesions to play. And this is a very recent study, just came out last year, about 40 patients who underwent adhesiolysis, and they found a significant improvement in patients who had a mild adhesiolysis, mild adhesions and adhesiolysis, good outcomes. Severe adhesions, even when you did adhesiolysis, the outcomes were not that good. So the spontaneous conception rate following hysteroscopic adhesiolysis was higher in patients with minimal intrauterine adhesions than those with severe adhesions. Septum, again, something many of us are very happy to see in when we put a hysteroscope, because very easy to remove, and yes, the patient will benefit. But we all know routine practice, yet there is no evidence to support the surgical procedure in these women. And this again is a huge Cochrane review, came out just a couple of years ago. So though across the room, I think everybody treats the septum, it has yet not been proven. And there are plenty of studies to reinforce that, whether removing a septum helps or does not help in patients with infertility. So what about T-shaped uterus? That's always been a dilemma. A lot of people are very, very aggressive with T-shaped uterus, and sometimes we're like, what are these people doing? They're operating every patient. And so this was a nice study, again, very recent, 2022, that patients who had either congenital or acquired T-shaped uterus because of some infections or tuberculosis, etc., and hysteroscopic metroplasty was done using scissors, followed by estrogen progesterone treatment. And after hysteroscopic metroplasty, the live birth rates increased dramatically. You can see from 23 to 79% in the congenital and even in the acquired group. Huge improvement. So hysteroscopic metroplasty may improve reproductive outcomes. And this again is a bit of a change, because we used to say there's nothing like a T-shaped uterus. And now again, we are addressing that issue one more time. And we know that coming together really is a beginning, keeping together is progress, and working together is success. The reason I bring this up is because hysteroscopic surgery and ART really have to work in collaboration to give the best outcomes for our patients. So should every patient do a hysteroscopy prior to IVF? And this is a very controversial topic. Again, very recent study last year, 12 studies, 6 RCTs there. The available scientific evidence suggests that performing routine hysteroscopy before first IVF improves the clinical pregnancy rate, but the live birth rate is unaffected. So no point in putting a hysteroscope prior to every ART. There were studies in the past which told us that just doing a hysteroscopy improved pregnancy rates, but improved clinical pregnancy pregnancy rates, not live birth rates. So no benefit at the end of the day. Things change when we come to recurrent implantation failures and recurrent pregnancy losses. We know that when we find a patient of RIF, we do a hysteroscopy. If we find a pathology and we treat it, the outcomes are better. But very recently, the ESHRE guidelines came out in 2022, and look what they have said. The guidelines, many of us follow these guidelines to the T. There is no benefit of using hysteroscopic septum resection to reduce the rate of pregnancy loss. Metroplasty not recommended for biconjugate uterus. There's insufficient evidence supporting hysteroscopic removal of submucous myomas or polyps. So even something as basic as polyps and submucous myomas, there is a controversy in RPL patients. There is insufficient evidence to remove fibroids which distort the cavity as well. And there is insufficient evidence of removal of the benefit of surgical removal of adhesions. So in other words, the ESHRE guidelines are saying that do almost nothing, which I think is also too radical. I mean, when you get a patient with recurrent pregnancy losses, what do? You have to help them in some way. And ESHRE says none of these things really help. So since most of our regular indications have been taken away, what do? Are there any newer indications for hysteroscopy? And there are many. Believe me, difficult embryo transfer is a situation when you get very, very stressed out. Everything is perfect and then you can't put that embryo in easily. Because of cervical stenosis, 30% of patients may have either a very tortuous cervical canal, some little projection ridges inside the cervical canal, difficult embryo transfer. And so hysteroscopy, particularly, most of us don't have flexible hysteroscope, but a very thin office hysteroscope is a very good procedure. And you can actually overcome cervical stenosis in most of the patients, making your subsequent embryo transfer very simple. So this is one good indication. And you can see how the cervical stenosis is being treated. Just with a scissor, you can go and gradually dilate under vision and, keep on dilating till you do. Obviously, this is between cases, not in the actual cycle of IVF. Another topic, and I'm on the FIGO Committee for Menstrual Disorders, a huge amount of focus on isthmocele surgical repair, and it's probably going to be included in your Palm-Cohen classification very soon. That's the discussion going on, because isthmocele actually may be a cause for infertility and, of course, intermittent postmenstrual bleeding. And even interstitial pregnancy may result from there. The number of cesareans that are happening, we are seeing a lot more isthmoceles. So surgical correction of isthmocele improves symptoms and or fertility. And this can be done hysteroscopically, laparoscopically, or combined method. So this is one new, very important indication for hysteroscopic surgery, along with maybe laparoscopy. Another thing most of us don't address, and we will need to do this very soon, is chronic endometritis. And patients with RIF and chronic endometritis were diagnosed using hysteroscopy and histopathology together. And if you treat this either with oral antibiotics or even intrauterine infusion of antibiotics such as gentamicin with dexamethasone, the pregnancy results you can see were dramatically better, from 30 to 50% improvement. Live birth rates increased. Again, intrauterine infusion is not something which is common here, but I've seen in the US they do a lot of intrauterine antibiotic infusion, bladder infusions for recurrent UTIs, again, which is something we don't do commonly, but that's something which has a role to play. For adenomyosis, we've never looked at hysteroscopy, but see the recent studies that hysteroscopy has actually revolutionized the approach to adenomyosis. Of course, only superficial adenomyosis. So when you put in a hysteroscope, many times you can see the little brown dots, little focal superficial adenomyosis. You can actually treat it there. You can take biopsies, you can shave it off, and you may be able to address a problem of superficial adenomyosis. And I was really surprised to see this paper. Early, good, stage 1, grade 1 endometrial carcinoma. You can actually treat it conservatively. And this was such a sort of an interesting or inspiring study that 6 patients with proven grade 1, stage 1 endometrial cancer, all of them were just treated with hysteroscopic tumor resection followed by progesterone therapy for 6 months. And of course, these patients are followed very closely with biopsies, etc. And one of them became pregnant, delivered normally, and when they tested later, no cancer. And all these 6 patients followed up for a period of time had no recurrence of that endometrial cancer. So it's a really good fertility preservation technique when you diagnose it early and the patient is young and seeking fertility. What about retained products of conception? I saw this patient very recently. Many patients now after abortion, tablets when they take particularly, they come back with retained products. And the conception rate for hysteroscopic resection of this incomplete abortion was 81% compared to 65% for non-hysteroscopic management. So go ahead when you have a patient with, retained products. I didn't have time to edit this video. But when you have a patient with the recurrent, with retained products of conception, put in a hysteroscope. Don't do a DNC. Put in a hysteroscope and remove these products under vision, and you'll get excellent outcome and no postoperative adhesions, which is the most important thing. And so, of course, every single thing comes with its problems and complications, and which is why we have to be careful and not jump into doing surgery for every single patient of ours. There is sometimes pain, particularly when you use a large hysteroscope. There can be lacerations, false tracks are created. There can be bleeding and sometimes perforation, infections, fluid overload less now because we hardly use glycine, but it is there if you use it. And then, of course, late complications such as suboptimal outcomes, incomplete resections, adhesions postoperative, and rarely also venous air embolism. So even a procedure like hysteroscopy cannot be taken lightly. You have to be very careful. And when there is good literature saying the procedure should not be done, and if you do it and you get into a complication, you will have problems justifying why you did that procedure. So be very careful in today's times of litigations and patients being very, very well informed. And so I'll conclude by these 1 or 2 slides. What is the current and the future state of surgery? Again, a recent opinion saying that the increasing success of IVF has definitely caused a shift in the emphasis with many downstream consequences. There's increased recognition that except for submucous myomas, other myomas are unlikely to affect fertility and miscarriage. And so be careful when you ask for myoma surgery for every odd patient with a myoma that you see. Cesarean section defects have been recognized as having significant reproductive consequences, and surgical management is now standard of care. And the division of uterine septum, like I mentioned earlier, remains controversial, and a clear answer is still elusive. So some of the things we took for granted have been taken away from us as a regular procedure. So could IVF replace reproductive surgery? The answer is no. And this answer is coming from Jacques Denet, who we all know is one of the pioneers of endoscopic surgery in the world. Reproductive surgery is certainly not dead. It lives on with the promise of restoring the functional anatomy to enhance chances of pregnancy. This was my logo when I was president of IG. Eventually, all of us need to follow this. Minimum intervention, maximum benefit. Thank you. Thank you very much.